Patho and diagnosis: inflammatory disease of the bladder that usually is chronic. The cause is unknown, but usually affects females. The patient typically reports moderate to severe bladder and pelvic pain and urinary frequency and urgency. Chronic inflammation can cause the bladder to become scarred and stiff, which reduces its capacity. Ulcers may form in the bladder lining and bleeding may occur. The condition is diagnosed by cystoscopy. Other diagnostic measures may be performed to rule out other pathologic conditions such as cancer. Medical treatment, directed towards symptom management and attempts to treat possible causes. Among the drugs that sometimes are helpful are tricyclic antidepressants, antispasmodics, bladder anesthetics, calcium channel blockers, urine alkalinizers, and NSAIDs. A drug that brings symptomatic relief to many is pentasam polysulfate, Almiron. Other treatments include stretching the bladder under anesthesia, instillation of various medications, including dimethyl sulfoxide, into the bladder, and electrostimulation. Some sources advise dietary and activity changes and heat application. Cystectomy is an extreme measure that is necessary in some cases. Nursing care: patients are usually treated as outpatients, so you are more likely to encounter them in clinic or home settings than in hospitals. It's important to show acceptance of the patient and empathy for the disruption of lives caused by this disease. It's a physiologic illness, not a psychologic one. Your primary role is teaching and support. The Interstitial Cystitis Association is a source of general information as well as dietary advice to avoid bladder irritation. Complementary and alternative therapies: biofeedback may help some patients to deal with the symptoms of interstitial cystitis. Patient teaching: avoid acidic foods, coffee, tea, citrus products, aged cheeses, nuts, vinegar, curry, hot peppers, alcohol, and carbonated drinks. Calcium glycerophosphate, pre-leaf, is an OTC urinary alkalinizer that your physician may suggest. Wear close clothing that fits loosely around the waist and lower abdomen. A local support group may be available for education and encouragement. Discuss pyelonephritis, nursing care, and patient teaching. Pyelonephritis, inflammation of the renal pelvis. It may affect one or both kidneys. Acute pyelonephritis most often is caused by an ascending bacterial infection, but it may be bloodborne. Chronic pyelonephritis may be persistent or recurrent and results in damage to the renal parenchyma, functional tissue. It most often is the result of reflux of urine from inadequate closure of the ureterovesical junction during voiding. Progressive scarring results in atrophy of the affected kidneys, and hypertension and renal ischemia develop. Chronic pyelonephritis, usually caused by long-standing UTIs with relapses and reinfections, may lead to chronic renal failure. If the patient progresses to renal atrophy and end-stage renal disease, dialysis or transplantation is the only means of keeping the patient alive. Signs and symptoms: acute, include high fever, chills, nausea, vomiting, and dysuria. Severe pain or a constant dull ache occurs in the flank area. Patient with chronic often complains of bladder irritation, chronic fatigue, and a slight aching over one or both kidneys. Medical treatment: goal is to prevent further damage. Mild symptoms usually can be managed on an outpatient basis. Severe symptoms commonly are treated in the hospital. Antibiotics, urinary tract antiseptics, analgesics, and antispasmodics may be ordered. Long-term antibiotic therapy may be prescribed for patients who have repeated acute infections or chronic infection. Additional medications may be needed to treat hypertension. Adults are advised to drink at least 8 8-ounce glasses of fluids daily. For fluids may be ordered if the patient has nausea and vomiting. Dietary salt and protein restriction may be imposed on the patient with chronic disease. If an obstruction or congenital anomaly is present, it should be treated. Urine samples must be obtained for follow-up cultures to determine whether the infection has been resolved. Nursing care, general assessment of patient with urinary tract disorders is performed. When caring for the patient with pyelonephritis, record the presence of related signs and symptoms, a history of previous urinary tract disorders, any predisposing factors, and the effects of the infection on ADLs. Interventions. Acute pain, administer analgesics as ordered when the patient reports pain. Antibiotics and antiseptics do not provide direct pain relief, but eventually help eliminating the cause of the inflammation. Activity intolerance, pain and systemic symptoms of infection contribute to fatigue and activity intolerance. Assist with ADL and schedule activities to allow for periods of uninterrupted rest. If patient is being treated at some, advise family members of the patient's need for additional rest. Encourage the family to relieve the patient of some responsibilities until recovered. Deficient fluid volume and imbalanced nutrition, less than body requirements, adequate food and fluids are very important for the patient with pyelonephritis. If nausea and vomiting occur, inform the physician and administer antiemetics as ordered. Record food and fluid intake and fluid output. If the patient is unable to take the recommended 2 to 3 L of fluid daily, fluids may be prescribed. Be careful when forcing fluids to avoid circulatory overload. In the older patient, a sudden increase in fluid volume may result in HF. Possible signs of this complication are bounding pulse, rising blood pressure, dyspnea, and edema. Ineffective self-health management. If patient will be taking medications at home, review the drugs and stress the importance of taking them as prescribed. Explain the importance of flow-up evaluation to assess effects of treatment and the need to report suspected recurrence to the physician immediately. Patients with chronic pyelonephritis must be adequately prepared for self-care. Patient teaching. Take your medications exactly as prescribed. Report adverse effects for specific drugs to your physician. Be sure to complete the course of therapy. Limit your physical activity and exercise as advised by your physician. Even after this infection has been treated, drink at least 8 8-ounce glasses of fluids each day to dilute urine and to reduce the risk of recurrence. If advised, follow dietary protein and sodium restrictions. Discuss polycystic kidney disease, acute glomerulonephritis, and nursing care for both disorders. Polycystic kidney disease. Polycystic kidney disease is a hereditary disorder. 2 types exist, 1, childhood and 2, adult. In adults, it usually is manifested by age 40. It is characterized by grape-like cysts in place of normal kidney tissue. The cysts enlarge, compress functional renal tissue, and eventually result in renal failure. They also may create pressure on nearby organs. As the kidneys lose the ability to concentrate urine, hypertension and HF develop. Often, cystic lesions are found on other organs. Chronic infection contributes to progressive loss of function. Signs and symptoms. This slowly progressive disorder begins with various types of pain, dull, aching abdominal, lower back, or flank pain, or it begins with colicky pain that begins abruptly. Medical treatment. Supportive treatment is recommended to preserve kidney function, treat UTI, and control hypertension. Infections should be treated promptly with appropriate antibiotics. As the disease progresses, kidney function decreases and end-stage renal disease develops. Dialysis, nephrectomy, and transplantation are then treatment options. Genetic counseling is advised for these patients because each of their children has a 50% chance of having the condition. Acute glomerulonephritis. Pathophysiology. Glomerulonephritis is an immunologic disease characterized by inflammation of the capillary loops in the glomeruli. Several immunologic mechanisms can cause acute glomerulonephritis. For example, the patient may develop antibodies against antigens in the glomeruli. A common type of glomerulonephritis follows an infection of the respiratory tract caused by group A negative hemolytic streptococcus. An antigen-antibody reaction results in inflammation of the glomeruli and scar tissue forms. Glomerular permeability increases, allowing proteins to leak into the urine. The glomerular filtration rate decreases and nitrogenous wastes accumulate in the blood. Both BUN and serum creatinine levels rise. Acute glomerulonephritis usually resolves completely, but some patients develop chronic glomerulonephritis or progress to irreversible renal failure. Signs and symptoms: urine becomes tea-colored as output decreases. Peripheral and periorbital, around the eyes, edema is evident. As glomerular filtration decreases, mild to severe hypertension occurs and hypervolemia, increased blood volume, results. Medical diagnosis. Diagnosis is based on patient assessment and laboratory tests. A urinalysis is done to detect proteinuria and BC casts. Blood studies measure BUN, creatinine, and albumin. Streptococcal antibody tests indicate whether the patient has had a streptococcal infection. Findings in blood and urine studies tend to vary from one patient to another. Renal ultrasound, renal biopsy, or both also may be ordered. Medical treatment. Acute glomerulonephritis is treated with diuretics and, for severe hypertension, antihypertensive medications. Antibiotics are indicated if evidence of current streptococcal infection exists. In the acute phase, bed rest is ordered to prevent or treat heart failure and severe hypertension from fluid overload. Activity restriction usually is continued as long as urine tests show blood or protein or if BP is elevated. Fluids, sodium, potassium, and protein may be restricted until sufficient recovery of kidney function occurs. When fluid overload has been corrected, moderate activity is permitted, but the patient still needs sufficient rest to allow the kidneys to heal. Because some patients with acute glomerulonephritis develop renal insufficiency, follow-up is very important. If renal failure develops, dialysis is necessary. Patients who progress to chronic glomerulonephritis acquire end-stage renal disease in 1 to 30 years. Nursing care of the patient with acute glomerulonephritis. Assessment. For the patient with acute glomerulonephritis, it is especially important to note signs and symptoms, recent infections, especially sore throat or skin lesions, and changes in urine characteristics. During the physical examination, inspect the area around the eyes, the extremities, and the abdomen for fluid accumulation. Assess tissue turgor. Evaluate respiratory and cardiac function for evidence of excess fluid volume, dyspnea, tachycardia, hypertension. Accurate intake and output records and daily weights help to assess the kidney's ability to excrete excess fluid. Interventions. Excess fluid volume. Administer diuretics as ordered. Maintain careful records of fluid intake and output. Instruct patients and family members about the importance of accurate records. If fluids are restricted, explain the need for the restriction and help the patient to plan the timing and amounts of allowed fluids. Fluid restriction can be very distressing. It helps to present fluids in small containers rather than serving an ounce or two in a large glass. If the patient has edema, special skin care is needed. Handle the patient gently because taut, swollen tissue is damaged easily and heals slowly. Activity intolerance. Activity intolerance may be due to infection, accumulated toxins, or anemia. During the acute illness, discourage activity to allow the kidneys to heal. Explain the importance of rest for recovery. Schedule activities to allow for periods of uninterrupted rest. Of course, the patient on bed rest is at risk for complications of immobility, skin breakdown, pneumonia, muscle weakness, joint stiffness, constipation, and thrombus formation. Therefore, have the patient change positions, cough and deep breathe, and gently exercise joints periodically. Nursing measures to prevent the complications of immobility are discussed in Chapter 21. Ineffective self-health management. The patient needs to understand that rest, dietary restrictions, and medications promote recovery. Provide assistance with ADL. Emphasize the need for follow-up care. When the patient is discharged, reinforce the importance of reporting any signs of recurrence such as changes in urine characteristics or edema. Instruct the patient to increase activities gradually as the edema and fatigue resolve. Anxiety. The patient with acute glomerulonephritis may be very concerned about the possibility of developing a chronic, life-threatening condition. Give the patient an opportunity to ask questions and share concerns. Helpful interventions may include empathetic listening, providing factual information, and referrals to other professionals. Discuss polycystic kidney disease, acute glomerulonephritis, and nursing care for both disorders. Discuss renal calculi and nursing care. Renal calculi/urolithiasis. Most common in Caucasian men, expected to be in 12% of men and 6% of women. Uric acid kidney stones mostly occur in Jewish men. Factors include diet, genetic factors. Pathophysiology. Most calculi are precipitations of calcium salts, uric acid, magnesium, ammonium phosphate cysteine, substances normally found in urine. Factors that foster the development of calculi. Concentrated urine. Excessive intake of vitamin D, animal protein, oxalate, sodium, sucrose, vitamin C, calcium-based antacids. Low dietary calcium intake. Familial history. Hyperparathyroidism, gout, diabetes, obesity, gastric bypass procedure, Crohn's disease, renal tubular acidosis. Immobility, urinary stasis, sedentary lifestyle. Lack of kidney substances that inhibits calculi formation. Pathophysiology. Continued urine is normally acidic, normal pH, 4.5 to 8, and various substances precipitate in acidic or alkaline urine, causing urinary calculi formation. UTIs caused by Klebsiella, Proteus, and Pseudomonas are linked to calculi formation as the organisms secrete wastes that make the urine alkaline. Most calculi start in the kidneys, then move to the bladder. S/S, pain, which indicates where the calculi is by the site of pain. Dull flank pain equals calculus in the renal pelvis or stretching of the renal capsule from urine retention. Calculi in the ureters is indicated by pain in the abdomen that radiates to the perineum or groin. The ureters go into a colic spasm to move the calculi along and stop the obstruction. Nausea, vomiting, hematuria, and S/S of UTI may also be found. Medical diagnosis, helical CT scan is preferred. Routine urinalysis, culture and sensitivity, composition determination of the stone is done if the calculus is captured. Other tests may be done to rule out other causes of pain. Medical treatment, stones are passed randomly. Ambulation is used to help move the stone. Pain is managed by NSAIDs, opioids, and antispasmodics. Antibiotics are given when internal manipulation of the stone is done / when infection is present. Procedures to destroy / remove it include ureteral stent placement, lithotripsy, shattering of the stone, cystoscopic stone removal, percutaneous nephrostolithotomy, hole is made to the stone, then it's shattered and removed and a nephrotomy tube is left to promote healing. Prevention. To prevent the recurrence of urinary calculi, patients usually have a high fluid intake, regular exercise, have specific dietary requirements to prevent the excess of certain elements, take meds to alter urine pH. Other meds might be taken like thiazide diuretics, potassium citrate, and magnesium supplements. Nursing care. Assessment. Pay attention to personal and family history of calculi. Describe usual fluid intake and diet, pain, changes in urine, temp, palpate and percuss flank and abdomen while noting any pain, tenderness, and a distended bladder. Intervention. Acute pain, administer opioids, NSAIDs, antispasmodics. If pain is intermittent, have patient ambulate. Impaired urinary elimination, maintain INO records, strain and examine all urine for the calculi and send them to the lab for analysis. Risk for electrolyte imbalance, give antiemetic as needed, give 4 fluids as ordered to maintain an output of 2 L/day, monitor for signs of circulatory overload like tachycardia, bounding pulse, dyspnea, edema, hypertension, etc. Ineffective self-health management. Reinforce need to consume adequate amounts of fluids, advise patients to drink 2 glasses of water at bedtime and 2 glasses of water when awakening at night to avoid in this pattern should be followed for life to reduce risk of calculi formation. If doctor prescribed diet, reinforced instruction or have dietitian do so. Postoperative care. Explain the procedure and answer any questions. Risk for infection. Position tubes for free flow of urine at all times. Keep records of drainage from each tube. If patient has a flank incision, check the air around the dressing for drainage. Frequent dressing changes using stereotyping may be required. An ostomy point may be used to collect drainage and permit accurate measurement of the drainage. If nephrostomy irrigations are indicated, flush the kidneys with no more than 5 mm of warm sterile saline at a time. Decreased cardiac output. Be alert for signs of excessive bleeding, infection, pulmonary complications, Inspect dressing and drainage hourly for the first 24 hours and report bright red excessive serosanguineous drainage, increasing pulse, restlessness, decreasing BP. Report indications of infection like odor, cloudy drainage, temperature above 100 degrees Fahrenheit. Take measures to reduce risk of infection like maintaining close drainage system, changing wet dressings promptly, using strict aseptic technique when handling tubes or dressings. Ineffective breathing pattern, monitor patient's pulmonary status. Help the patient turn cough and deep breathe every 2 hours. Assisted patient in using an incentive spirometer. I hope the patient splint their incision whenever they cough with pillows or folded blankets. For the first 1 or 2 postoperative days, administer analgesics before turning coughing or deep breathing. Encourage adequate fluid intake and early and frequent ambulation, which helps prevent atelectasis and pneumonia. Discuss urologic trauma, renal cancer, and nursing care. Urologic trauma. The kidneys sustain 50% of all urologic injuries. Trauma may be penetrating or blunt. Penetrating injuries most often result from knives or guns. Blunt trauma occurs when a force is applied to the abdominal wall and the energy is diffused into the abdominal cavity. Examples are motor vehicle accidents, contact sport injuries, falls, and intentional injuries. Blunt injuries to the kidneys produce lacerations or contusions. The ureters are rarely injured with blunt trauma, while they are disrupted most often by penetration and require anastomosis. The bladder may rupture from blunt trauma if full, but is rarely harmed when empty. The urethra is most likely to be injured in men because of its unprotected anatomic location. Signs and symptoms. When blunt trauma is suspected, the patient is observed for bruising on the abdomen or in the flank area. They should be assigned for signs of shock, tachycardia, restlessness, hypotension, pallor, pain, and a palpable abdominal or flank mass. Bruising over the flank that occurs with retroperitoneal bleeding is called Gray-Turner sign. The most common indication of urologic trauma is hematuria. Before catheterizing a patient with suspected trauma, carefully inspect the urethral meatus. If there is blood in or around the meatus, a urologist should perform the catheterization or insert a suprapubic catheter. Medical diagnosis. The physician may order a KUB, urography, CT scan, or ultrasound to determine the extent of injury. Diagnostic peritoneal lavage may be performed to determine whether there is bleeding in the peritoneal cavity. A positive finding necessitates surgery to find and eliminate the source of bleeding. Renal cancer. 80% of renal malignancies are adenocarcinomas. Primarily mean aged 50 to 70 years are affected. A renal tumor may reach considerable size before it is detected. Renal malignancies metastasize to the liver, lungs, long bones, and the other kidney. Direct extension of the tumor may be found in the ureter. Early symptoms are anemia, weakness, and weight loss. Painless, gross hematuria is the classic sign, but it usually occurs in the advanced stage. A dull ache in the flank area is a late symptom. Medical diagnosis. The physician may be able to palpate a mass in the flank area. CT scan is the primary diagnostic tool for renal cell cancer. Diagnostic tests and procedures to study the mass may include ultrasonography and MRI. Medical treatment. Removal of a kidney, also called a nephrectomy, may be necessary. Radical nephrectomy involves removal of the kidney and its adjacent tissue, adrenal gland, renal artery and vein, and local lymph glands. Nephrectomy is the surgery of choice for renal cancer. Before a nephrectomy, the renal artery may be occluded to reduce the blood supply to the tumor. Partial nephrectomy may be an option when the tumor is small. Renal tumors are not responsive to radiation or chemotherapy, but radiation is sometimes used as a palliative measure for inoperable cancer. Biotherapy with alpha interferon and high-dose interleukin-2 may be used for patients with metastatic disease. Nursing care. When a patient has a suspected or confirmed renal malignancy, very few signs and symptoms may exist. Inquire about weakness, fatigue, and any changes in the urine. Explore the patient's emotional state, usual coping strategies, and support systems. Preoperative care. Before renal surgery, the patient's primary nursing diagnoses are ineffective coping related to potentially fatal disease and deficient knowledge of tests, procedures, and effects of renal surgery. Thorough explanations of diagnostic tests and preoperative teaching provide needed information. Assure the patient that one functioning kidney can sustain adequate kidney function. Tests are done to confirm that the unaffected kidney functions adequately before a nephrectomy. Serum and urine laboratory tests are usually ordered to serve as baseline data for postoperative comparison. Older patients are most likely to have renal insufficiency, and they eventually may need renal dialysis after nephrectomy. The teaching plan includes what to be expected in the postoperative period and how to turn, cough, and deep breathe. Postoperative care. After nephrectomy, monitor vital signs to detect fluid volume alterations related to blood loss or fluid retention. Record intake and output as another measure of fluid balance and renal function. Routinely check drains and tubes to ensure proper function. Monitor dressings for drainage. Once the dressings have been removed, inspect the wound for intactness and signs of infection, excessive redness or swelling, purulent drainage. Determine the patient's comfort level. Auscultate breath sounds and bowel sounds. Anticipate breath sounds and bowel sounds. Anticipate some emotional distress and encourage the patient to express thoughts and feelings about having cancer. Acute pain related to incisional tissue trauma. Obtain a complete description of the patient's pain. Incisional pain is intense at first and requires prompt administration of analgesics. Because of prolonged position during surgery, there may be muscle aches in the opposite side and flank area. Medication can be supplemented with position changes and back rubs. Risk for deficient fluid volume related to dehydration, blood loss. Intravenous fluids are given intravenously. The physician normally orders approximately 3 L of fluid daily. Maintain accurate intake and output records. At first, the urine may be measured every 1 to 2 hours. Notify the physician if less than 30 milliliters is produced in an hour. When the patient can be weighted, daily weights are even better measures of fluid balance than intake and output. BUN, serum creatinine, serum electrolyte, and urine-specific gravity are assessed. Monitor the nephrectomy patient for bleeding. Frequently check the dressing drainage. Be careful to check under the patient because blood flows to the most dependent area. Sometimes the dressing is dry and intact, but the patient is lying in a pool of blood. Ineffective breathing pattern related to proximity of incision to diaphragm. It is especially important to have the patient turn, cough, and deep breathe every 1 to 2 hours. You can help by supporting the incision during respiratory exercises. Supervise use of an incentive spirometer to encourage deeper inspiration. As soon as ambulation is permitted, assist the patient out of bed. Be careful not to place tension on tubes and drains. Risk for injury related to decreased peristalsis caused by bowel manipulation during surgery. Anesthesia and manipulation of abdominal organs cause temporary cessation of peristalsis in the intestines. Until peristalsis returns, the patient is not permitted anything by mouth. Paralytic ileus is common after nephrectomy. A nasogastric tube may be inserted as well as attached to suction during surgery. Suction keeps the stomach empty, reducing the risk of nausea and abdominal distension. The return of peristalsis is detected by active bowel sounds and the passage of flatus, gas. Auscultate the abdomen for bowel sounds and observe for abdominal distension. Ambulation promotes the return of peristalsis. Risk for infection related to break-in skin. During dressing changes, use strict aseptic technique. Montgomery straps may decrease irritation from the adhesive tape if frequent dressing changes are required. Ineffective coping related to diagnosis of cancer. Encourage the patient to talk and clarify concerns, listening empathetically, providing requested information, and referring the patient to expert counselors. Explore usual coping strategies and sources of support. Deficient knowledge of postoperative limitations related to lack of information. Before discharge, caution the patient not to lift or participate in strenuous activities for 8 weeks. Contact sports are prohibited for life because trauma to the remaining kidney could eliminate all kidney function. Discuss bladder cancer, nursing care, and patient care for urinary diversion. Bladder cancer. The most common malignancy of the urinary tract, with more than 70,000 new cases diagnosed each year in the U.S. Occurs most often in men 60 to 70 years old. The ureteral orifices and the bladder neck are the most common sites of bladder cancer. The tars found in smoking tobacco, aniline dye found in industrial compounds, and tryptophan all have been implicated in the development of bladder cancer. Signs and symptoms. Most common sign is painless, intermittent hematuria. Other signs include bladder irritability, infection, with dysuria, frequency, and urgency, and decreased stream of urine. Medical diagnosis. The physician may order a urinalysis with urine cytology and cystoscopy. Cystoscopy is done to visualize the bladder and permit biopsy of observable lesions. Additional testing may be done, including CT, MRI, IVP, CT urogram, chest radiography, and radionuclide bone scan. Medical treatment. Bladder malignancies respond more favorably to chemotherapy than do kidney tumors, but surgery is the treatment of choice. The type of surgery depends on whether the cancer is superficial, invasive, or metastatic. Superficial cancers involve only the bladder mucosa or submucosa, or sometimes both. Superficial lesions with low recurrence rates may be treated with cystoscopic resection and fulguration or with laser photocoagulation. Cystoscopic resection is the removal of tissue through a cystoscope with a special cutting instrument. Fulguration is the use of electric current to burn and destroy tissue. Laser photocoagulation is the use of an intense beam of light, argon laser, to destroy tissue. Two other surgical procedures for bladder cancer are segmental bladder resection and radical cystectomy with pelvic lymphadenectomy, excision of lymph nodes. A segmental bladder resection is done for a single, primary tumor too large to remove by cystoscopic resection. It involves removal of the tumor and adjacent bladder muscle, a procedure that decreases the size of the bladder. A radical cystectomy is removal of the entire bladder and adjacent structures with diversion of the ureters. In men, the prostate is removed. In women, the urethra, uterus, fallopian tubes, ovaries, and anterior vaginal wall are removed. This procedure is reserved for malignancies that are untreatable with less conservative measures. Because this is a very extensive surgery, an optimal state of health before surgery is desirable. Chemotherapy, radiation, or both may be done before or after surgery, depending on the extent of the malignancy. Sometimes chemotherapeutic drugs or immune-stimulating agents are instilled directly into the bladder. This procedure is called intravesical therapy. A drug such as Bacillus calmette-guerin, BCG, or mitomycin C is administered into the bladder through a urinary catheter. The patient's position is changed at 15-minute intervals to ensure that the drugs reach the site of the lesion. After about 2 hours, the drugs are drained from the bladder. Treatment may be repeated weekly for 6 to 12 weeks, followed by a program of maintenance therapy. Urinary diversion. When the bladder and urethra must be removed completely, urine must be allowed to drain through another route, called urinary diversion. Several types of urinary diversions exist: ileal and sigmoid, conduits, continent reservoir, cutaneous ureterostomy, and nephrostomy. The neobladder is a reservoir that is attached to the urethra so that the patient voids through the urethra. To form an ileal conduit, a portion of the ileum is resected from the small bowel. The ureters are implanted in the ileum, one end of the ileum is closed, and the open end is implanted on the abdominal surface as a stoma. Urine is excreted through the ileal conduit rather than the urethra. A urinary drainage pouch is attached to the skin to collect the urine. A sigmoid conduit is formed by the same procedure, except that a section of sigmoid colon instead of ileum is used. A continent reservoir is an internal pouch created from a segment of bowel. Urine collects in the pouch and is drained with a catheter at intervals. A ureterostomy brings the ureter to the abdominal surface, where urine is eliminated through a stoma. A nephrostomy is the placement of a tube in the kidney so that urine may drain through the tube into an external collection device. Nursing care plan. Assessment. Complete description of urinary signs and symptoms. Fatigue and weight loss are significant and should be noted. Health history may reveal use of tobacco or exposure to carcinogenic chemicals. Explore the patient's emotional state, coping strategies, and sources of support. Diagnoses. Acute pain. Impaired skin integrity. Risk for infection. Risk for injury. Deficient knowledge. Discuss acute kidney injury and nursing care. Acute kidney injury. Causes. Causes of acute kidney injury can be prerenal, intrarenal, or postrenal. Prerenal failure results from decreased blood flow to the glomeruli. Intrarenal failure may be caused by nephrotoxic drugs, kidney infections, inclusions of intrarenal arteries, hypertension, diabetes mellitus, or direct trauma to the kidney. Antibiotics, heavy metals, cleaning compounds, pesticides, and poisonous mushrooms may be toxic to the kidneys as well. Postrenal causes of AKI obstructions beyond the kidneys, causing urine to back up into the renal pelvis, resulting in hydronephrosis. Patients at risk for AKI include those having major surgery, experiencing major trauma, or receiving large doses of nephrotoxic drugs. There's an initial stage, oliguric stage, diuretic stage, and recovery stage. Medical treatment. Primary goal of treatment for AKI is to prevent further damage. Supportive measures aim to control symptoms and to prevent complications. Drug therapy. Oliguria is treated with diuretics, most often in osmotic diuretics such as mannitol or loop diuretics. Hyperkalemia, which typically accompanies the oliguria, is treated aggressively, and drugs are given intravenously to lower serum potassium, and they include hypertonic glucose and insulin, sodium bicarbonate, and calcium gluconate. Dietary modifications are based on consideration of symmetry, lights, and urea. Sodium and potassium allowances are determined individually. Adequate carbohydrates and fats are provided to prevent the breakdown of fat and protein. Essential amino acid supplements may be ordered. If the patient's nutrition needs are not being met by oral intake, enteral nutrition supporters instituted. TPN is needed if GI tract is not functioning. Fluids. Daily fluid needs usually are calculated by adding 600 milliliters to the previous day's fluid output. The extra 600 milliliters represents the daily insensible loss. Hemodialysis and peritoneal dialysis. Conditions that warrant hemodialysis when conservative measures fail include hyperkalemia, severe metabolic acidosis, pulmonary edema, rising BUN. Continuous renal replacement therapy. Continuous renal replacement therapy offers additional options for treating the patient. Can you replace in the artery and vein is connected to tubing that contains a blood filter and a collection device. The patient's blood flows through the tubing that contains a blood filter and a collection device. The patient's blood flows through the tubing and excess fluids, electrolytes, and waste or return to the patient. Nursing care of patient with AKI. Assessment. For the patient with acute kidney injury, monitoring fluid status is critical. Period intake and output records must be kept carefully. Daily weights are an effective means of assessing changes in fluid status. Period to be useful. Daily weights must be done at the same time every day using the same scale, with the patient wearing the same amount of clothing. Because hypervolemia is a major problem during the oliguric stage, assess for signs and symptoms of impending heart failure. Electrolyte can include alterations in serum potassium, sodium, calcium phosphate, magnesium. Interventions. Excess fluid volume. Assess and document for the status on an ongoing basis. Explain and reinforce fluid restrictions. The fluid allowance during this stage may be very limited. Remember to plan for fluids needed to take medications. When only a few ounces of fluids are allowed at a time, a small juice cup should be used rather than a large glass. Give diuretics as ordered and monitor the patient for adverse effects. Decreased cardiac output and deficient fluid volume. In the diuretic stage, patients produce large volumes of dilute urine. Deficient fluid volume becomes a possibility. The heart rate must increase to make up for the diminished blood volume. It is important to monitor cardiac dysrhythmias, changes in blood pressure, and shortness of breath. Give oral and 4 fluids as ordered with careful monitoring of output at the same time. Anxiety. The patient may fear death or chronic illness with the potential for financial ruin, loss of vitality, and dependence on medical care. Provide honest responses to questions about renal failure and its treatment. The patient may have a complete recovery period. This may take up to 1 year. Unfortunately, some patients do not recover, but instead progressed to chronic kidney disease. Those who do not improve need special support to help them learn to accept and deal with this major health deviation. Risk for disuse syndrome. The patient with acute kidney injury is very ill and may be immobilized. Therefore, you must attend to prevention of complications of immobility as well as to the acute renal problem, including skin care, turning, coughing, deep breathing, leg exercises, and measures to promote bowel elimination. Deficient knowledge. When the patient is acutely ill, provide basic information about the disease, diagnostic tests and procedures, and treatments. Explain their reasons for interventions such as fluid restrictions, turning, deep breathing, and leg exercises. As the patient improves, patient teaching should include management of fluids, diet, drug therapy, activity, and signs and symptoms that should be reported to the physician. Discuss chronic kidney disease and medical treatment. Chronic kidney disease is characterized by progressive destruction of the nephrons of both kidneys. The severity is described in stages, with the final stage, stage 5, being end-stage renal disease. The healthy kidneys compromise far more nephrons than needed. Therefore, a person can lose about 80% of the nephrons before kidney function becomes impaired. Creatinine clearance is an important measure of renal function. When it falls below 15 milliliters per minute, dialysis or transplantation becomes necessary. Chronic kidney disease is characterized by azotemia, increased nitrogenous waste products in the blood. Uremia is the term used when the condition advances to the point that the kidneys are unable to maintain fluid and electrolyte or acid-base balance. Uremia is also called end-stage renal disease. All of the causes of a key listed earlier may lead to chronic kidney disease. In addition, chronic renal infection may dispose the patient into progressive renal failure. However, the most common causes are hypertension, diabetes mellitus, and atherosclerosis sclerosis. S/S azotemia. The first function last in chronic kidney disease is the ability to concentrate urine. This results in an increase of waste products in the blood, despite producing large amounts of dilute urine. As the disease progresses, urine output typically declines until very little to no urine is produced. BUN is affected by protein breakdown. When BUN reaches or exceeds 70 mg/dl, dialysis is needed to reduce it. Insulin resistance. In renal failure, cells become resistant to the action of insulin. As a result, blood insulin and glucose levels rise. Hyperinsulinemia stimulates the liver to produce and triglycerides. Korean patients with chronic kidney disease have high serum levels of very low-density lipoproteins. Elevated lipids in the blood contribute to atherosclerosis. Discuss nursing care for patient with chronic kidney disease, include nutritional consideration. Frequent monitoring of changes in status is especially important. Fluid balance is evaluated closely. During hospitalization, accurate intake and output records must be kept. Be alert for signs and symptoms of excess fluid volume that can lead to cardiac failure. Warning signs include increasing edema, dyspnea, tachycardia, bounding pulse, and rising BP. Serum electrolytes are measured frequently, but you must still be alert for signs and symptoms of electrolyte imbalances. With chronic kidney disease, the nurse is most concerned with detecting hyperkalemia, hypocalcemia, and metabolic acidosis. Hyponatremia and hypovolemia are less common. Assessment of fluid and electrolyte imbalances includes characteristics of pulse and respirations, BP, mental status, and neuromuscular activity. Assessment of nutrition includes appetite, usually diet, weight gain or loss pattern, and prescribed diet. Determine how well the patient sticks to and understands their prescribed diet. Increasing confusion or loss of consciousness can be due to accumulated toxins or electrolyte imbalances. Emotional responses to a diagnosis of chronic kidney disease vary. Determine the patient's perceptions of the situation and identify usual coping strategies. Anxiety, fear, disturbed body image, depression, and lowered self-esteem are common. Long-term effects of kidney disease and its treatment put the patient at risk for many complications. Monitor bowel elimination for either constipation or diarrhea. Monitor for signs and symptoms of local or systemic infections, redness, swelling, foul drainage, fever, increased WBC count. Inspect the skin for bruising, bleeding, or trauma. Evaluate sensation of the extremities. Ask if sexual dysfunction has been a problem and obtain a description of the problem. Explore patient understanding about chronic kidney disease, its treatment, and self-care measures. Document the patient's ability to perform ADL. Specific nursing diagnoses and goals vary based on the individual patient data. Excess fluid volume related to fluid retention. The patient's ability to excrete fluid decreases as renal failure progresses. Diuretics may be used to treat fluid retention in early stages. They are not used once dialysis is begun. Fluid intake may be restricted. If intravenous fluids are ordered, closely monitor the rate of infusion. Antihypertensive drugs may be needed to control blood pressure and digitalis may be given to support cardiac function. Dosage adjustments often are needed because kidney failure affects the ability to excrete these drugs. Administer medications, monitor for side effects, and teach the patient how to take them after discharge and what adverse effects to report. Patients with excess fluid volume require comfort and safety measures. Edematous legs are injured easily and heal slowly. Protect them from pressure or trauma. If cardiac failure and dyspnea develop, position the patient with the head elevated to ease breathing. Cerebral edema causes confusion and decreasing consciousness. Implement safety precautions for the confused or semi-conscious patient. Most drugs are excreted in the urine. Persons with impaired renal function are at risk for drug toxicity. Imbalanced nutrition less than body requirements. Anorexia, nausea, vomiting, and stomatitis interfere with food intake. Sodium, potassium, protein, and sometimes fat restriction may make the diet less appealing. Frequent mouth care and small feedings encourage intake. Explain the importance of good nutrition. The person preparing the patient's food at home should be including in dietary instructions. Vitamin supplements are routinely ordered because of dietary restrictions. Monitor weight to evaluate both fluid and nutritional status. Teach the patient and the caregivers about medications and status monitors. Nutritional considerations. Renal failure results in an inability of the kidneys to excrete wastes and maintain fluid and electrolyte balance. The nutritional goal of renal failure is to modify the diet so that the work of the kidneys is reduced. Fluid intake may be restricted to 1,000 to 1,500 ml/day. Sodium and potassium are restricted, including meds, to maintain electrolyte balance in those on dialysis. Protein is restricted in patients with renal disease, and any protein ingested should be high in essential amino acids. Eggs, meat, poultry, fish, and milk products are examples. People with renal calculi should increase fluid intake to maintain at least 2 L of urine output daily. They should avoid foods that lead to the forming of calculi. People with low serum calcium are increased risk for the formation of calculi. Risk for acute confusion related to effects of uremia on the nervous system. Renal failure affects the central nervous system and peripheral nervous system. Cerebral edema and elevated metabolic wastes in the blood can cause confusion, slowed thought processes, lethargy, and loss of consciousness. Protect confused patients and orient them to person, place, and time. Present information simply and repeat as needed. Avoid sensory overload by reducing environmental stimuli and demands on the patient. For safety reasons, assign the patient to a room close to the nurse's station. Put the bed in the low position and keep the call bell within reach. The effects of renal disease on the peripheral nerves can lead to loss of sensation in the extremities, peripheral neuropathy. These patients are at risk for injury. Inspect the affected areas daily for any signs of injury. Pressure, ill-fitting shoes, or external heat or cold can cause serious injury before the patient is aware of it. Teach the patient about peripheral neuropathy and how to prevent injuries. Ineffective coping related to multiple life changes. Anxiety and fear are often experienced in these patients. Explore the patient's coping strategies and identify factors that interfere with adjustment to renal disease. It helps for the patient to have a regular primary nurse so that a therapeutic relationship can develop. Nurses can help by talking to patients and having them focus on the sources of their distress. It is important to be accepting of the patient's thoughts and feelings. Do not give false reassurance or tell patients